Good morning. My name is Dr. Fiona He. I'm a hematologist-oncologist at the University of Minnesota. The topic of this talk is inflammaging in the cancer patient, how to age better. During this talk, I will discuss normal aging, age-related pathologies in cancer survivors, and accumulation of senescent or aged cells as a process observed in both normal aging and prematurely induced by cancer therapies. Finally, we will discuss strategies to combat accumulation of senescent cells and our ongoing studies at the University of Minnesota. Before we discuss accelerated aging, we first need to establish what normal aging looks like. Aging is defined as a progressive decline in physiological function associated with a steady increase in mortality. The prevalence of frailty or loss of physiological reserve increases with age and approaches 10% in community-dwelling elderly. Frailty can be measured through dynamic measures such as grip strength, walk test, self-reported physical activity, and symptoms of weight loss and exhaustion. Aging is also associated with an increase in chronic medical disease burden. The goal of aging research is to improve lifespan as well as health span. The hallmarks of aging at a molecular level have been well described. Genomic instability can be damage from inside the cell, such as errors in DNA replication, and outside the cell, including physical, chemical, and biological agents. Premature aging diseases such as progeria have increased DNA damage accumulation. Telomeres are ends of linear DNA sequences. A specialized protein called telomerase is required to replicate the ends. Over time, there's a cumulative loss of telomeres. Telomere deficiency in humans is associated with premature development of conditions such as pulmonary fibrosis and bone marrow failure syndrome such as dyskeratosis congenita and aplastic anemia. Epigenetic alterations refer to signals that alter if and how much DNA is expressed, which means turned into proteins, without changing the DNA sequence itself. Loss of proteostasis deals with unfolding of proteins. Proteins are then either refolded, degraded, or aggregated. Some diseases like Alzheimer's are associated with abnormal aggregation of proteins. Deregulated nutrient sensing occurs with aging. Dietary restriction turns on anti-aging pathways and slows down pro-aging pathways. Dietary restriction also increases lifespan in mice and primates. Mitochondria are the powerhouse of the cell and how energy is generated. With aging, the efficiency of energy creation decreases. This dysfunction can be a source of reactive oxygen species, which are pro-inflammatory free radicals. Cellular senescence is a stable arrest of the cell cycle associated with changes in cytokine and growth signals from the cell. Because senescent cells cannot die on their own, a process called apoptosis or programmed cell death, senescent cells are removed by the immune system. DNA damage from chemotherapy or radiation can induce cellular senescence. Stem cell exhaustion refers to decreased ability to regenerate specialized cells from stem cells. Altered intercellular communication refers to increased inflammatory signaling and decreased immunosurveillance, or an ability for the immune cells to clear cells that don't belong. These molecular features of aging give rise to increased risk of age-related diseases at an organ level, such as heart disease, cancer, arthritis, diabetes, and dementia. The cancer survivor population in the US is anticipated to grow from a current estimate of 17 million in the US in 2019 to around 22 million by 2030, with 2/3 being over age 65. Now that we've established what normal aging looks like at a cellular and organ level, how can we apply the concept of aging to cancer survivors? Cancer survivors have unique treatment regimens, which consist of chemotherapy, radiation, immunotherapy, targeted therapy, and hematopoietic stem cell transplant. Of these, the effects of chemotherapy, particularly alkylating agents, and radiation are known to induce DNA damage and increase cellular senescence, corresponding to an accelerated aging phenotype. This looks like reduced physical function, more chronic diseases, and potentially earlier death relative to their age. Dr. Ness led a study of the St. Jude lifetime cohort, which included adult survivors of childhood cancer with an average age of 33. Frailty and pre-frailty were tested in this population. Frailty included meeting at least 3 of the following criteria: low lean muscle mass, reduced strength, slow walking speed, low energy expenditure, and fatigue. Pre-frailty included meeting 2 of these criteria. The study concluded that 8% of this cohort was frail compared to 0% in age-matched peers. This was comparable to the frailty rate of an older population in the cardiovascular health study cohort that were older than age 65. The prevalence of pre-frailty was 22%, also comparable to the rate in older adults. Frail cancer survivors had a 2.2 times increased risk of new onset chronic conditions and a 2.6 times increased risk of death compared to controls. Similar findings were reported by Dr. Mukta Arora in the bone marrow transplant survivor study. This cohort included adults between the ages of 18 and 64 who were receiving bone marrow transplant and their age-matched siblings. Frailty was tested using a survey done at a median of 8 years post-transplant. The prevalence of frailty was 8.4%, higher than 0.7% in age-matched siblings, corresponding to an 8 times higher rate of frailty after adjusting for other variables, such as socioeconomic status, sex, age of study participation, and race. The St. Jude cohort also underwent screening for age-related conditions such as heart dysfunction, lung dysfunction, hearing loss, elevated cholesterol, and primary ovarian failure. The solid line in these graphs indicate the incidence after screening tests, and the dotted line indicates incidence before screening. This shows that some conditions were not diagnosed prior to formal screening, such as heart valve disorders, whereas others, such as pituitary disorders, were already diagnosed prior to enrolling on the study. The incidence of all of these disorders increases with age. By age 45, the prevalence of heart dysfunction approached 20%. Lung dysfunction was even higher, around 60%, and there was a 30% risk of breast cancer by age 45. At age 45, the estimated cumulative prevalence of any chronic health condition was 95% and 80% for a serious, disabling, or life-threatening chronic condition. To summarize these studies, there is evidence that cancer survivors have a higher incidence of frailty and age-related chronic medical conditions than their age-matched peers as a result of their cancer therapies. Learning about mechanisms of accelerated aging in cancer survivors may identify those who are most vulnerable to effects of cancer treatment and allow for earlier interventions to minimize toxicity. I will now transition this talk to cellular senescence, an important hallmark of aging with an extensive body of preclinical data supporting its relevance in reducing lifespan and health span. In 1962, Leonard Hayflick was the first to describe cellular senescence as a process that limits proliferation or growth in normal human cells in culture. These cells had unlimited capacity for cell division, not unlike that seen in cancer cells. We now know that senescent cells have a distinct secretory phenotype, or an array of cytokines and growth factors, that give rise to chronic low-grade inflammation. In aged individuals, up to 15% of cells in the body can be classified as senescent. Senescence can be induced by some of the hallmarks of aging that we discussed earlier. The most relevant to cancer survivors is DNA damage from chemotherapy and radiation. Induction of the senescence-associated secretory phenotype, or SASP, including cytokines like IL-1 alpha, IL-1 beta, and IL-6, induce remodeling of other cells surrounding it, including scar tissue formation, abnormal blood vessel growth, and recruitment of certain populations of immune cells. There are also both pro-cancer and anti-cancer roles of senescent cells, dependent on its environmental context. This diagram shows proposed models of senescence. Panel A demonstrates wear and tear damage and normal aging that leads to an expected rate of tissue deterioration. The second column includes disease-related senescence from organ-specific insults, such as smoking, with an increase in the rate of chronic disease beyond that of normal aging. Finally, therapy-induced senescence includes systemic DNA damage from chemotherapy or stress of engraftment from organ transplant, both with a compromised immune system and a decreased potential to clear senescent cells. This also results in accelerated aging. Several murine models have tested disease phenotypes associated with senescent cell accumulation. Schaefer and colleagues reported high cellular senescence markers in idiopathic pulmonary fibrosis, a disease with lung scarring, with improvement in lung function and physical health with elimination of senescent cells. Musi and colleagues reported that neurons, or brain cells, containing tau protein neurofibrillary tangles have high senescence gene expression. Removal of senescent cells improves the burden of neurofibrillary tangles and reduces neuron loss in mice. Ross and colleagues reported that removing senescent cells reduced aortic calcifications or plaque buildup in mice. Farr and colleagues reported an increase in bone mass and strength with removal of senescent cells. Baker and colleagues used a progeroid mouse model, which is a premature aging disease, and found that eliminating senescent cells delayed the onset of several age-related conditions and improved physical function. These studies and others highlight that senolytics, or drugs that remove senescent cells, can improve both lifespan and health span in mice. Biomarkers of senescence are of great interest to identify senescent cells without the need to culture these cells to measure their replicative potential, a time-consuming and expensive process. There are several biomarkers of senescence that have been tested. One of the most reliable tests to estimate senescent cell burden in the body is measuring gene expression of p16-inc4a, a cell cycle protein that is upregulated in senescent cells. This is most easily detectable in T cells, a type of white blood cell that circulates in the blood. Other measures of senescence include direct measurement of telomere length, measurement of a protein called senescence-associated beta-galactosidase that is elevated in senescent cells, measuring protein levels of SASP cytokines and chemokines in the blood, and looking for end products of an active pathway called NF-kappa beta that is turned on in senescent cells. It is advisable to test more than one of these biomarkers to have more confidence in identifying senescent cells. Liu and colleagues first introduced p16-inc4a as a biomarker of chronological aging by testing its levels in various types of circulating blood cells and a range of age populations. They found that CD3 positive cells, or T cells, had the highest levels of relative p16 expression, and that the levels went up about 1 log, or 10 times, with each decade of age. They also found that p16 expression was higher in smokers versus non-smokers, and with higher total smoking pack years. There was a correlation of lower p16 levels with more exercise. Based on this study, p16-inc4a has been one of the most highly tested biomarkers of senescence. Levels of senescence-associated secretory phenotype cytokines, chemokines, and growth factors were measured in a community-based adult cohort of all ages, including subgroups undergoing surgery for valve replacement and ovarian cancer. They measured frailty index as a surrogate for biological age. Chronological age was associated with increased levels of 8 SASP factors, and 2 SASP factors were independently associated with frailty index in all subject groups after adjusting for chronological age, body mass index, and sex. They identified a panel of 7 SASP factors that had the highest predictive value for adverse post-operative outcomes, more so than chronological age or biological age. This study suggests that SASP biomarkers correlate with frailty and can predict adverse medical outcomes. In the next few slides, we will discuss what is known about senescence in cancer patients. Sanoff and colleagues studied 2 populations of early breast cancer patients. In a prospective study of breast cancer patients receiving adjuvant chemotherapy, they used p16-inc4a and ARF gene expression to evaluate the senescent cell burden pre and post chemotherapy. They reported an increase in senescent cells post chemotherapy, which remained elevated at 1 year. In another study, including about 1/3 of patients who had received chemotherapy versus 2/3 who had not received chemotherapy, they observed higher P16 INK4A levels in the chemotherapy group versus no chemotherapy at a level roughly equivalent to 15 years of aging. In the bone marrow transplant population, P16-4A levels were tested pre and 6 months post-transplant. Both autologous and allogeneic stem cell transplant were associated with a significant increase in P16 levels. Notably, the T cells post-allogeneic stem cell transplant by 6 months were donor-derived, so any senescence would be induced by the stress of engraftment and inflammatory complications of transplant rather than chemotherapy or radiation. Patients who had prior autologous stem cell transplant and then underwent allogeneic stem cell transplant had the highest levels of P16. A twofold increase in P16 is considered roughly equivalent to 10 years of aging. In a mouse model, Demaria and colleagues induced senescence by giving doxorubicin, common chemotherapy agent. They then eliminated the senescent cells by using ganciclovir, a drug with a kill switch in this engineered mouse model. The effects of removing senescent cells include reduced bone marrow suppression and faster count recovery, reduced cardiotoxicity, improved physical activity and strength, and there were also effects on delaying cancer recurrence. In these graphs, outcomes of running capacity, grasping capacity, fractional shortening of the cardiac muscle cells, and ejection fraction of the heart are shown. The gray bars indicate the control group who did not receive chemotherapy. The red bars are mice who received chemotherapy, and the orange bars are mice who received chemotherapy followed by senescent cell elimination with ganciclovir. You can see that all measures decrease with chemotherapy and then return close to baseline after senescent cell elimination. Drugs that clear senescent cells are broadly known as senolytics. Large drug screens that look at targeting of cells with high senescence gene expression have identified promising candidates such as dasatinib, a tyrosine kinase inhibitor, quercetin, a flavonoid, heat shock protein 90, which destabilizes a marker called AKT, which is highly expressed in senescent cells, and MDM2 antagonists, which increase P53 and attenuate the senescence-associated secretory profile. There are also drugs that utilize the ability of senescent cells to digest galactosides using beta-galactosidase, thus allowing for uptake of encapsulated cytotoxic drugs. Of these drugs, only dasatinib and quercetin have been tested as a senolytic combination in humans. Another powerful way to target certain cell populations is by engineering chimeric antigen receptor T cells, or CAR T cells. These T cells are collected from the donor, programmed to recognize the target, in this case UPAR, which is highly expressed on senescent cells, and are engineered with receptors that cause direct and robust cell killing. This platform is approved to treat some types of blood cancers and has promise as a senolytic agent as well. Dr. Kirkland's lab at the Mayo Clinic has completed a small pilot study of the senolytics dasatinib and quercetin in patients with idiopathic pulmonary fibrosis, progressive condition of lung scarring. This oral drug combination was given 3 days per week over the course of 3 weeks. There were no discontinuations of drug, and there were improvements in multiple measures of physical function, including walk distance, chair stands, and a short physical performance battery, including balance testing. There is no significant change in lung function. Although this is a small study, it's intriguing and with a good safety profile and paves the way for larger studies of senolytics in high-risk populations. There may be positive effects from exercise in reducing cellular senescence. Recall that one of our previous slides showed lower P16 levels in those who did more exercise. In this study using a mouse model, exercise was able to reduce cellular senescence biomarkers, including senescence-associated beta-galactosidase, in mice who were fed a fast food diet, as shown in panel B. These blue dots recommend accumulation of senescence-associated beta-galactosidase. Whether this study can be replicated in humans is a different story, as we're not allowed to lock patients in rooms with treadmills. But perhaps not everything needs to be treated with drugs. At the University of Minnesota, we have recently developed a senescence core laboratory dedicated to testing human samples for biomarkers of senescence. We have several ongoing pilot studies in cancer survivors. On the top left, we've added P16 correlative testing to an ongoing study of bone marrow transplant and breast cancer survivors more than 2 years out from chemotherapy, that's being led by Dr. Mukta Arora and Dr. Ann Blaze. We will be testing how senescent cell burden correlates with measures of frailty, cognitive dysfunction, and comorbidity in these patients. On the top right, we will be testing biobanked samples of allogeneic stem cell transplant patients with acute leukemias pre and post at 100 and 100 days post-transplant to see how senescent cells accumulate in the early transplant period and whether it associates with transplant-related complications. On the bottom left, Dr. Shernan Holton is leading a community-based strength resistance training program in survivors of bone marrow transplant and solid tumors, which we've added senescence correlative markers to evaluate whether exercise is able to attenuate markers of senescence. And finally, we are testing newly diagnosed cancer patients who undergo multi-agent chemotherapy to see if baseline or post-therapy senescence correlates with chemotherapy complications. Future directions for the field of senescence in cancer survivorship include more studies on human samples and integrating biomarkers of senescence into prospective clinical trials to gain more information on how senescence relates to clinical outcomes. There are also organ-specific effects of senescence that require more study. How best to target senescent cells is a hot area of research, with the goal of therapeutics that are safe and well tolerated, and yet effective to clear senescent cells while minimizing undesired off-target effects. Which populations are at the highest risk of detrimental effects of accelerated aging that should be targeted for early phase clinical trials is also an area of debate. I'd like to acknowledge my collaborators and mentors at the University of Minnesota Division of Hematology, Oncology, and Transplantation, who've helped to design and support our ongoing studies. I'd also like to thank Dr. Laura Niederhofer and Dr. Matt Youssefzadeh, our leaders in the Institute of Biology of Aging and Medicine, who have implemented the senescence core this past year and provided their valuable expertise on this topic. And last but not least, thank you to cancer survivors and their families for being a part of survivorship awareness and research. I'd like to thank you for your time, and I'm happy to take any questions.